Hello, everyone, and thank you, all of you, for being with us in this digital event. Today, our webinar is about the FIP program, Shaping the Future of Self-Care Throughout Pharmacy. So we will be tackling the topic of self-care. However, today's topic is health and self-care literacy for the management of minor ailment in the pharmacy. We're mostly talking about children fever management. An interesting topic that we would like to welcome all of you to it, whether you're joining in the early morning, midday, or late on your day. I hope you will enjoy this webinar with us. Allow me to introduce myself and the moderator also with us. So we'll be having two moderators. Will be both of us moderating this webinar. My name is Marwan Ail, and I am FIP Projects Manager, Workforce Development and Evidence and Impact. I am also the Pharmacy Education Journal Editor. I will be co-moderating this webinar with my colleague, Noor Al-Tahla. Noor is the FIP Project Coordinator for Equity, Sustainability, Policy and Development. Welcome, everyone. So, before starting our webinar and having our esteemed speakers having their presentations, allow me to have some announcements about this event. This webinar is being recorded and live streamed via YouTube. The recording will be available on our website at events.fip.org. You may also ask questions using the question box provided. And allow me to take the opportunity right now to tell you that we would appreciate having an interactive webinar. So please feel free to ask any question you have in mind related to the topic for our speakers, be it on the question and answers box, which is the preferred one, but if also you would like, you can ask it on the chat box. The preferred one is the Q&A, as we will directly know that you are asking us a question. And we will try as much as possible to answer all your questions, whether during the panel discussion or directly on the Q&A box. So you are welcome to provide any feedback to webinars@fip.org. And for all of you that are here, if you're still not a member of FIP, we encourage you to join us at www.fip.org. You go to the membership and to registration then after in order to become an FIP member. Today's event is sponsored through unconditional funds by Reckitt, and we would like to acknowledge this in our event. Allow me now to go to my colleague, the co-moderator of this event, Noor Al-Tahla. Noor, the floor is yours.
Thank you very much, Marwan. And hello, everyone. Thank you for joining us today. I'd like to introduce you to the FIP series of which this event is a part of, titled Shaping the Future of Self-Care Through Pharmacy. This program focuses on empowering patient self-care as it improves health outcomes and reduces the burden of diseases. Health and self-care literacy are key to empowering pharmacy-based self-care, and this is especially important when it comes to the management of minor ailments through pharmacy. Consisting of a series of 5 digital events focusing on 5 different health issues, this FIP digital program aims to examine how pharmacists can be enabled to improve health and self-care literacy. And approaches for 5 different areas of minor ailments are discussed, including embedding health and self-care literacy into education and training, developing self-diagnosis and self-medication protocols, widening access to patient information, and improving referral strategies. Today's event in specific will focus on the management of fever in children, which is particularly important as fever is a common symptom in children. Pharmacists hold a vital position in improving health and self-care literacy in the management of fever in children, and this is important because better health literacy allows parents to make informed decisions, recognize when to seek medical attention, and take appropriate steps to care for their child's health. Together with our esteemed panelists today, we aim to understand the clinical aspects and health literacy needs with regards to children's fever management, identify strategies for pharmacists to enable health and self-care literacy in the management of children's fever, as well as discuss enablers across education and training, care protocols and services, access to patient information, and referral strategies. I'd like to bring your attention to this FIP publication titled Empowering Self-Care, a Handbook for Pharmacists, which was launched in 2022 and has a specific chapter about children's fever. The main messages of this chapter indicate that this self-limiting condition is often worrying to parents that visit a community pharmacy looking for options to reduce their child's fever. Pharmacists can provide advice on checking the temperature and ensuring the child is comfortable, besides dispensing over-the-counter medicines if appropriate. More information on non-pharmacological measures is presented in the handbook, as well as a flowchart for decision-making that includes red flag symptoms. You can access the handbook through the QR code on the screen or the link. Without further ado, I'd like to introduce you to our panelists who will be sharing their knowledge and expertise on this topic with us. With us is Dr. Amy Howard from the United States, Jack Collins from Australia, and Jill Morgan from the United States. Starting off with Dr. Amy Kruger-Howard, who is a clinical faculty member at the University of Maryland School of Pharmacy, where she also earned her PharmD. She completed a 2-year pediatric pharmacy fellowship with a split focus in clinical practice and translational research, as well as a master's in health sciences with a concentration in global health systems. Previous and ongoing research projects include the implementation of caregiver peer mentorship for children living with HIV, taste perception and enhancing drug palatability, as well as designing patient-accessible medication information tools. She has received several interprofessional education grants through which she facilitated collaborations, expanding educational training in the areas of pediatric transgender care, health literacy, and best practices for interpreter services. So Dr. Amy Howard is unable to join us live today, but she has sent us this pre-recorded presentation to tell us more about the topic. Let's get started with the presentation.
Hello, everyone. Apologies for not being able to join in real time. My name is Amy Howard. I serve as clinical faculty for the University of Maryland School of Pharmacy. I specialize in pediatrics and more recently have turned my attention to health literacy. I also have a role as the representative of the Americas for the Health and Medicines Information section for FIP. In my brief talk today, my goal is to help attendees piece together what we need to know about fever in children and how it relates to caregiver health literacy. As pharmacists, our role in fever management is to communicate our knowledge to caregivers in a way that they will be able to understand it. I teach a weekly course on social determinants of health, particularly health literacy, and the use of plain language to increase patients' health literacy. Here in the United States, research has shown us that social determinants of health drive as much as 80% of health outcomes. It's therefore reasonable for us to assume that our ability to increase an individual's health literacy will have a dramatic impact on the individual's capacity to obtain, process, and understand that basic health information in order for them to make appropriate health decisions. In order to address an individual's health literacy, we need to think about numeracy, reading proficiency, and oral comprehension, all through the lens of health. We know that if you have proficiency in each of these areas, it's not correlated with higher health literacy, but a deficiency in any given area can set up an additional barrier that needs to be overcome in order to increase someone's health literacy. Using plain language is essential. We have to be sure that even someone with lower health literacy is able to access the information being provided. In my talk today, addressing a health-savvy audience, I may use medical jargon that I would otherwise avoid in conversations with my patients. I often find myself telling students to focus on the need to know information. We know that being stressed can decrease our ability to process and retain information. So when it comes to sharing information on fever management with a caregiver who may already be significantly stressed, we should limit the amount of information we're trying to cover and use tools like visual aids and written documents that will allow them to refer back when questions come up. So let's get into what I think are the basic need-to-knows about fever management. I think that a major misconception that caregivers have around fever, besides fever phobia, which Dr. Morgan will go into a little bit later, is the role of fever in the body and how to assess a fever in a child. So being sure that everyone has the same understanding. A fever is a temporary rise in body temperature that exceeds the normal core temperature. The rise is regulated by our hypothalamus, and it means that the body's thermoregulatory set point has gone up. The change in the set point and the body's response are managed by this feedback loop, and the changes in the set point are going to result normally from, say, a bacterial or a viral infection. When the thermal set point goes up, we're going to see a corresponding rise in the core temperature. The body is trying to reach homeostasis. The body's working to reduce the heat loss at the extremities and raise the core temperature. So clinically, a child may start having faster breathing, faster heart rate, they could shiver, and they might lose their appetite. All of these symptoms are happening as they're trying to shunt the temperature up in the core, and it's usually before a fever is even clinically measurable. So the disparity between a child's skin temperature and the core temperature really highlights the inaccuracy of using a gauge like putting our hand to the forehead in terms of measuring a fever. But we so commonly know that. If you Google fever management in children, more than 50% of the images that you see will demonstrate somebody putting their hand to a child's forehead. So there have been some systematic reviews on this and whether or not touch is a valuable diagnostic tool in fever, and what they concluded is that really the only predictive value that they have is in ruling out a fever. So if using touch is not appropriate to assess a fever, caregivers need a more accurate tool, and that's where thermometry comes in. In the context of health literacy, this is also where we need to ensure caregivers have good numeracy. Numeracy describes a person's ability to understand clinical and public health data. In fever, we want caregivers to use numeracy to understand how healthcare providers define fever and be able to assess whether a child is appropriate for home care. Thermometry is the best means for detecting an elevation in core temperature. The table I have shown here has a nice summary of the possible means of measuring a temperature. For sure, you want to avoid those fever strips or pacifier thermometers. They are not accurate. We know that rectal temperature, which isn't influenced by the ambient temperature, used to be gold standard, but there are many reasons why it's not really ideal for home monitoring. In a child with a rapidly changing core temperature, a rectal reading can lag behind, and also there's the risk of bowel perforation with inappropriate use. In 2018, there was a study that showed that infrared tympanic thermometry has better than 90% sensitivity for accurate temperature detection. However, I do want to note that these thermometers are generally built for adult ears, so to increase the accuracy when using it to take a measurement in a child, the caregiver should be taught that they need to take a temperature twice in each ear, and they record whatever number is the highest number they get. And in kids less than 3 years old, we want to pull the earlobe back and down and then aim the tip of the thermometer towards the child's opposite eye so that the infrared sensor aligns with their tympanic membrane. Once you have a number reading, then we have to think about how do we interpret the value. The chart also has numbers for what's considered a clinically significant fever. It's split into two columns. On the left is children less than 3 months, and on the right, children greater than 3 months. It's very important to stress to a parent that any infant 3 months or younger with a fever should be seen as soon as possible. They need to be assessed by a healthcare provider before the caregiver tries management of a fever at home. Otherwise, most fevers can be managed at home. Important symptoms to ask about in connection with a fever would be severe headache, seizures, the inability to wake the child. If a child is refusing to walk or refusing to move one of their arms or their legs, if they complain of a stiff neck or they have jelly-like stools, if the fever's been hanging out for more than 5 days, or if the child has an associated diarrhea that's lasted more than 2 to 3 days, or if they've been vomiting for more than a day. All of these signs tell us that we need to make prompt referrals so the child can be appropriately evaluated and treated. Another key aspect of fever management is to convey to caregivers that a febrile child should receive symptomatic care. That means we're simply trying to make the child more comfortable. According to the American Academy of Pediatrics, we are not treating to a number. Again, if the body alters the temperature set point, it's usually in response to something the immune system sees as an invader. It is the body's way to fight infection. A sleeping child should never be woken up for treatment of a fever. If they're able to sleep, let them sleep. Medicine should be used to treat the fever only when the fever is causing the child discomfort. Comfort care focuses on improving the child's well-being, watching for changes in their activity level, and making sure they stay hydrated. To prevent dehydration, parents should offer more fluids when a fever is present. Generally, intake should increase by 30 to 60 milliliters per hour in order to compensate for any potential fluid losses. This is particularly true if the child is experiencing any symptoms of diarrhea or vomiting. If a child were to show signs of dehydration, like a decrease in their normal urine output or their ability to make tears, a caregiver can offer water supplemented with oral rehydration salts. Although sports drinks are commonly used in place of oral rehydration salts, they can worsen diarrhea and might not be giving the appropriately balanced electrolytes to replenish losses. In keeping focused on comfort care, caregivers should use fever management methods that are proven to work. So we know that sponging and bathing are generally ineffective for alleviating fever. Bathing can actually lower the core temperature, but it fails to reset that thermoregulatory set point. And so when you bring a child out of the water, they can experience a rapid rebound in their temperature, and that increases the likelihood that they might have a febrile seizure. There are kind of homespun methods like wiping the palms and feet with alcohol or using iodine baths. Both of those should be avoided. They have risk of toxicity if they're absorbed through the skin. And we know that acetaminophen or paracetamol and ibuprofen are our agents of choice for relieving symptomatic discomfort in kids. There is still some debate on whether or not you can alternate between the two medications, though the American Academy of Pediatrics doesn't recommend this practice because it can lead to dosing errors. I believe Dr. Morgan is going to cover some of the important aspects of dosing medication in kids, but the main takeaway for caregivers is that if they're giving an oral liquid medication, they should be using a device that they can accurately measure, like an oral dosing syringe or a dosing cup, and healthcare providers should be making dosing recommendations in milliliters so that it will match those accurate measuring devices. So you can help caregivers to increase their health literacy as it relates to fever management in kids by providing education on the role of fever in fighting infection, ensuring that they know what number clinically defines a relevant fever, the warning signs that mean that a child should be seen before they manage the fever at home, reinforcing that treating a fever doesn't mean treating a number. It means providing supportive care to help the child be as comfortable as possible while a fever runs its course, and making sure that you stock and provide measurement tools that ensure caregivers can provide appropriate antipyretic medication doses as needed. So the medication may come with a dosing device. It's very important to make sure that you show the caregiver how to use how to measure the dose using the device based on the child's weight. Again, I apologize for not being able to be there in person and to participate in the panel questions. I hope that your understanding of some of the basics of health literacy, and particularly as it pertains to fever management, were addressed in my talk, and that you gained valuable information from this talk and others that you see today. Thank you. Hello, everyone.
Okay, wonderful. We started with the first presentation by Amy, and that was very informative. We want to continue in order to to go more into deep to our topic with Jack Collins. Jack Collins is a practicing community pharmacist and lecturer in Sydney, Australia. Dr. Collins' research interests include self-care, which we are talking about today, mental health, health policy, and health equity. Jack is an exco member of the Social and Administrative Pharmacy section and was the 2018 recipient of the FIP Young Pharmacists Group Award for Professional Innovation for his work exploring implicit bias in pharmacists. We're so happy to have Jack with us today. His talk will also be adding to the information we want to take from this webinar. Jack, the floor is yours.
Thanks very much, Marwan. Hello, everyone, and thank you for joining us today. It's nice to be talking about self-care, which is an absolute passion and interest of mine, given I did my PhD in it. So I think we'd start off just by focusing a little bit on self-care itself as a concept. And I think in pediatrics, it's quite interesting. Is self-care a bit of a misnomer? Most children, particularly when they're younger, don't really have an active role in their own healthcare. Their parents or other caregivers take care of that for them. So they're not really caring for themselves per se. It's more that there's a caregiver doing the care for them. So traditional definitions of self-care and self-medication typically omit children and other dependents. It's all just about the self. We don't really consider that in many circumstances, it's not just children. There may be other people who have a caregiver in the instance of disability, for example, intellectual disability or otherwise. So there's certainly some room for improvement with some of these definitions, I think, but the WHO thankfully has recently expanded that definition to move beyond the individual. So their definition now is that self-care is the ability of individuals, families, so it's recognizing that a family unit is important, as well as communities, so it does go beyond the individuals, to promote health, prevent disease, maintain health, which is an important part of self-care as well, and to cope with illness and disability with or without the support of a healthcare provider. And today we'll be talking a little bit about the support of the pharmacist in this role. There are so many people to consider when we're thinking about facilitating self-care of children in the pharmacies. So we may not even have the child in front of us, for example. A caregiver may come in by themselves, and you don't even see the child, yet you're giving advice on how to care for that child. So that's one thing to consider. We may have the child in front of us. How old are they? Can they speak to us? Can they give us useful information? Can we communicate information to them directly? Or is it more appropriate to rely on the caregiver? You might have, for example, another caregiver like a grandparent come into the pharmacy to pick something up, but then they might take that home and then the parents would be administering it. So there's a bit of a network of people. You also have perhaps teachers, if there's medicine that needs to go to school, probably less relevant for fever, given if a child's unwell, they're unlikely to be going to school. But for other self-care conditions in children, there's siblings, whether they're older siblings that might help out, or siblings who are also sick and need to be looked after as well. And any other caregivers, babysitters, there's any number of people that might be involved. So it's quite complex, and it's definitely extending well beyond just the child that happens to be unwell. So even self-care in itself moves well beyond the individual. So this is the self-care matrix, which was generated to sort of conceptualize the complexity of self-care and how many different levels there are in self-care itself. It's not necessarily just straightforward of taking a medicine when you feel unwell. Today, we'll probably, in the remit of the pharmacist, we're probably more focused on these particular aspects of self-care. So knowledge and health literacy, which we've just heard a lot about, and the rational use of products and services. So products probably, in this case, being antipyretic medicines. There's then also self-care behaviours, which the pharmacist can certainly influence or shape. The self-care context, so this is the self-care continuum. So this is where this condition sits along here. And certainly we're probably thinking in minor ailments. Most of the time, the fever is associated with, say, a common cold, for example. So it's a minor ailment. Of course, if it's a more severe infection, then it might be sitting further up that scale. And then even bigger, which is beyond the scope of most of us in what we do in pharmacy, is there's the self-care environment. So there's health policy, financial policy, the culture, the built environment, all of these things that move a little bit beyond what we do. So we'll focus on the bottom half. These are the steps in pediatric self-care. So kind of some of the way that I've conceptualized it. First of all, we identify that there's signs or symptoms, or the caregiver does identify that there's signs or symptoms in the child which are not usual. So if that's a fever, it might be accompanied with other associated symptoms of whatever condition it is. They might notice that the child's unwell. They may have used a thermometer, which we've just learned about how to do that correctly, to measure the temperature and notice that it's high. We need to reach a diagnosis, and I use the term diagnosis here in quotation marks because that means the caregiver may select what they think is wrong with the child. If it's a fever and elevated temperature, do they have a cold? Is it perhaps COVID-19 in this post-pandemic world? And even as pharmacists, we can't necessarily always reach a diagnosis necessarily in the pharmacy either. So it's our best to guess at what we think is going on. We then need to move on and choose treatments. The caregiver needs to then measure out a correct dose and administer the treatments, and then monitor the child. So if we think about where does the pharmacist fit into this process, the reality is there's absolutely room for the pharmacist to be involved at every single one of these steps, whether that's directly by speaking to the child or speaking to the caregivers, or providing advice and education on how to appropriately manage each of these steps in fever management when that's being looked at by self at home. There are quite a few misconceptions in fever management, some of which we've already heard about first. So fever phobia, which Dr. Morgan will be talking a little bit about in the next presentation, or a fixation on temperature. So parents become quite obsessed with the number that they're seeing on the thermometer rather than, is the child well? If the child's otherwise well and they have a low-grade fever, we may not even need to treat it. It's this idea that if you have a fever, there's something wrong and we need to do something about it. In an otherwise unwell child, it can probably just be left alone. What the research has shown, which is quite interesting, is that caregivers appear to be quite influenced by packaging and branding of products. There's an image of a teddy bear or really like cuddly and warm fuzzy things, they tend to be drawn towards those products. So we do need to consider how advertising and the pharmaceutical market itself may influence some of these self-care decisions by parents. Unfortunately, that means that while they're distracted by the pretty branding and things like teddy bears, they are disregarding, unfortunately, dosing directions, warnings, and other important aspects of product labels. So in countries and markets where you may have less standardized labeling on products, that information may be permitted to be printed on the label in quite small font, in ways that's not clear, with branding and nice images taking over a lot of the packaging. So certainly as a pharmacist, that is a role for us to draw their attention to, as medicine experts, the bit that we consider to be important, which is how to actually dose and use the medicine. On top of that, there is the challenge that caregivers may socially medicate children. And sometimes some parents report saying that it gives them perceived control over their child's behavior. This is quite concerning, of course. That's probably not quality use of medicines. So again, as the medicine experts, we have a role to challenge some of these misconceptions and make sure that parents understand what medicines do in terms of course, fever management, which is what we're talking about today, but illness more broadly. When we have some misconceptions pop up, some ways that we might try and approach those are to discuss thoughts on fever management with caregivers. So what would they like? What are their usual practices? What would they like to get out of it? What's their rationale for wanting to use a medicine? Does the child appear to have quite a high fever? They're feeling unwell, not eating, not sleeping, quite lethargic. All those instances where we probably would elect to use an antipyretic medicine. Discuss how they would usually use the medicine and what their usual dosing schedule is. That gives you a bit of an idea of how they do it at home, because we can tell them what we want and say, okay, do this, do that. that means they can still go home and dose however they like. So we kind of try to get a feel for how they use the medicine at home. It's a really good opportunity for you to identify perhaps some gaps or misunderstandings in their knowledge on how to dose and how to use medicines. And it's an opportunity for you to correct those. So always looking for opportunities for education about fever more broadly, the use of medicines, non-pharmacological management, and also, of course, when they actually need to see a medical practitioner if we think something's a little bit more serious, or if they can return to the pharmacy for further advice for something as well. I think something that's becoming more prominent in the age of mass and misinformation at the moment is thinking about the less reliable sources of information consumers have access to. So it's not just medical professionals and trusted websites that they can see. There's forum and all kinds of social media where parents might get together, say, in a discussion board and discuss things. Oh, when it's my child, I do this, they're this age, and I give this many mils of paracetamol. We need to consider that parents are simultaneously digesting that alongside the information that we're giving them. So directing people to reliable sources of information, or perhaps identifying and challenging some of those misconceptions they get from those sources, is important. We just need to also perceive things through the consumer lens. So we've got this, they walk into perhaps their medicine cabinet at home or the pharmacy, they've got all these different products in front of them, different sizes, different flavors, different strengths, along with all those dosing devices, and they have to try and make a decision on how to interpret these. If we then take one of those products and look at the dosing information, this is what we get met with. So they've got an age, a weight, and a dose they need to try and interpret how to look at this. And research has shown that parents really struggle with this. They don't know, my child might be 8 years old, but they weigh, say, 22 kilos, or lower or higher. How do I then adjust that to dose? Do I just take an average? I might give them a lower dose because I don't want to give them too high of a dose. So getting to this decision is certainly something where the pharmacist should be able to help out. And it was really encouraging earlier to hear that we should be giving them a dose in mils of a product, so it's a little bit clearer. Then by the time they figured out the dosing in mils, they then have to use an appropriate device to measure out and administer the dose. Parents might choose spoons, they might use all kinds of things that we really wouldn't recommend. So making sure parents know how to appropriately measure out and administer medicines is really important. Certainly there's been studies where these kinds of products have been put in front of parents, and they'll often choose things like a teaspoon or something they would regularly have at home. Definitely room for education there. And it's challenging because each product will come with a different measuring device too. So it might be more useful for them to use a consistent device, such as one clear oral syringe. So some tips for that we can do to educate parents when we're teaching them about administering medicines is to use a syringe, preferably an oral syringe. And it can be confusing. They need to know where the plunger needs to go, for example, how to measure it out. If that person isn't particularly literate, that could be challenging for them too. So something I do sometimes is get like a permanent marker, a black marker, and mark on the syringe itself where they need to pull up to, rather than them trying to read numbers, which can be small. It's accurate measurement and aids dosing, which is great. So the one thing we should advise parents not to do is not to direct the squirt directly at the back of the child's throat, because it can cause them to spit it back up. So sort of towards the sides at the back of the mouth, and then it will just be swallowed. Making sure that they know the correct dose intervals, which can be a bit confusing because paracetamol or acetaminophen and ibuprofen have different intervals. So parents might mix up the two. And it can be useful, I think, to advise parents to write down the time of the dose and the amount they gave. That way, if a different caregiver comes to give the second dose or a later dose, so they've handed over, someone's gone to work and there's a different person there looking after the child, they can see when the dose was given and how much as well. If the child happens to spit out any of the dose, we'll just have to take that as it is and wait for the next dose before giving any more. So think about if you can advise caregivers and they can mix it with a small amount of food or drink. If you give it before eating, they may be more likely to swallow it, which is great. It's nice to explain the purpose of medicines to children so that they know why you're giving it to them. This is going to help with your temperature. Even, from an age where they can begin to understand anyway, it's great to try and involve children in those decisions and, give them that kind of right of consent to an extent, as when they're younger. And it's certainly not ideal to ever refer to medicine as candy or to use it as a threat. That's not safe use of medicines. It's creating an unhealthy relationship between medicines and that child. So strictly keeping them to being a therapeutic thing that will help them feel better. In terms of the pharmacy, when we look at some opportunities and strategies we might have, it's to ensure that all staff who are involved in giving out medicines and advice are adequately trained in the use of medicines in children and in fever management. Definitely sees each interaction as an opportunity to engage in education. So if someone just comes in, oh, I'm just here to get some paracetamol syrup, at a bare minimum, make sure that they're appropriately dosing it and using an appropriate dosing device. Of course, ideally, we should absolutely make sure that there's a therapeutic indication as well. Definitely avoid falling into the have you used this before trap, which is what I think of when we ask someone, have you used this medicine before? And they say, yes, we go, great, here you go. It's not really a useful history taking question in lots of ways. Of course, that means we know that they've had experience with the medicine. That doesn't mean that they've been using it correctly. So if you are going to use the have you used this before question in order to determine if someone has experience with it, don't then just assume that they're going to go home and know what they're doing. That's not an excuse for you to not follow up with advice. You're better off repeating yourself and telling them something that they already know than not saying anything at all. If your pharmacy has a strong social media presence or other communication channels like flyers or catalogs or whatever it might be in your practice setting, consider if that's something that might be useful for you to share common information and some safety tips. So if, for example, it's cold and flu season and you're seeing a lot of fever in children, would it be useful for you to have a post on your social media about how to appropriately use medicines in children, for example? And is there also room for you to engage in your local community, perhaps give an education seminar at a local school or a daycare? Look, this will obviously vary based on your practice setting, but these are kind of ways that the pharmacy can really get involved in their community and do a bit of an outreach in terms of education. Finally, consider the physical environment. So where are the products located? Are they near pharmacy? Are they near staff? Can you see if someone's standing there looking? Are staff accessible if that person has any questions? Is there someone around? What kind of signage can you add? So this is sponsored signage, so perhaps not the best idea, but ask a team member if what is available for your needs. So perhaps coming up with your own signage like that, just to prompt people to actually speak to someone and make sure that they're getting the right product and they're going home to use it correctly. Resources are really important. So make sure that as pharmacists, you familiarise yourselves with the local resources and fact sheets, which may be useful to yourself or staff as training materials, but also some that you can give to consumers. So that might be government endorsed ones, consumer groups, your local professional pharmacy organisations or FIP resources that may be useful for staff and consumers. Written information is obviously very useful in general, but if there's multiple caregivers, it can be great too. If you've got a grandparent coming in to speak to you, but it's the parents at home that will actually be looking after the child, then there's nothing stopping you from giving them some written information to pass on. Writing down dosing might be appropriate. You may be able to generate labels for products as well with appropriate dosing. Consider what works in your practice environment, but these are the kinds of things that will be really useful and they're not very resource intensive at all. You know your own communities best, particularly if you're working in community pharmacy. So you need to tailor what resources are going to be most useful to them. And if there isn't one that you think is useful, why not make your own? In the pharmacy I work in, we have a couple of resources that we've designed in-house because none of the sort of official ones have really met the needs of our patients. So if you think you can pull together some information and make a nice resource yourselves, there's absolutely nothing stopping you from doing that. And I encourage that. I think that's nice. Finally, I would just like to mention the FIP Self-Care Handbook. So if you haven't looked at this, there's a QR code there and a link to the file as well. So please take a look. This covers some common conditions where pharmacists can be involved in self-care. And children's fever, as you can see, I've got a screenshot of here, is one of them. So if you haven't taken a look at that, please go look at it. It's a fantastic resource from FIP. So just the key take-home messages from me is that there may be many caregivers involved in the self-care of children experiencing fevers, so we need to consider the complexity of the situation and how that interplay might pan out. There are many misconceptions in fever management and the use of medicines in fever. Certainly a role of the pharmacist to address some of those misconceptions, challenge them and give people correct and accurate advice. Pharmacists can leverage their position as accessible and trusted medicine experts to improve health literacy in this area. Thank you very much.
Thank you, Jack, for the wonderful presentation. So just to note that we had one question in the chat box asking about the resource that Noor mentioned at the beginning of the webinar, and then Jack, you mentioned it at the end of your part presentation, and we had the QR code. So I hope that the person who asked about this, the link to those to this publication, you can access it from the QR code that was just shown, presented, or you can go to the FIP library at the FIP website, and you can find all the publications that FIP has published, including the self-care publication. Now, allow me to go to our next speaker. We're going to Dr. Jill Morgan. Jill is a professor and chair of practice, science, and health outcomes research at the University of Maryland School of Pharmacy. She practices at the IPE, Pediatric GI Clinic at the University of Maryland, Midtown in Baltimore. She received her PharmD from the University of Illinois at Chicago and completed residencies at the University of Maryland Medical Center. Jill served as the chair for the American Association of Colleges of Pharmacy, the AACP, Administrative Services Section, and is the chair for the Pharmacy Academy and National Academies of Practice. She received the AACP Administrative Services Section Award for sustained contribution to administrative practice in pharmacy, education, and Excellence in Innovation Award, and Mentor of the Year Award from Maryland Pharmacists Association. She has also the Burdem Award from the Maryland Society of Health System Pharmacy and the University of Maryland Board of Regents Faculty Award for Mentoring. Jill, the floor is yours to continue the presentation about our topic.
Wonderful. Thank you very much. And thank you for inviting me to join you all today. I am excited to talk to you more about fever in children. Next slide, please. My part of the talk is going to cover more about education and training and even creating care protocols that we can use within our pharmacies to help treat fever inside of kids. And I have to say that so much wonderful information has already been shared today, and let's keep going. So next slide, please. I think it's important to understand that one of the most persistent misconceptions surrounding fever in children is that the thought that fever can lead to seizures and brain death and brain damage and death. But parents need to understand that fevers, just a fever, does not cause brain damage or death. They need to understand that a fever is different from heat stroke, okay? That fever is our body's way of protecting us. A fever actually helps us fight off infections, as shown here in this infographic, right? So if we get a fever, it's our way of telling our body that we need help from our immune system to fight this off. And so we need to share that information with parents. Parents need to be reassured that a fever isn't going to cause their child permanent harm. Now, a question might come up about febrile seizures, and I think that this condition is very rare. It only occurs in about 2% of all children, and it's more associated with children that have predisposing risk factors, or so a genetic predisposition, or they've been in a NICU. Those kids are also a little bit more likely to have it. So this is something that I think we need to be aware of. Fever phobia, we know, was first described back in 1980 by Dr. Barton Schmidt. And he coined this term in order to talk about the concern that parents have when their kids have a fever. Right now, 20 years later, Crossetti and colleagues repeated that study and found out that parents were still afraid of fevers, as you can see here by this other infographic. 73% of moms fear the potential of their child getting a high fever. Other studies that have been done looking at what number, right? Because people worry about numbers. So 81% of parents that were surveyed thought that a fever of less than 38 degrees Celsius is dangerous. And 89% of caregivers said that they would give medicine to their child, and 86% would schedule a visit to the doctor, even if their child was looking well, just because of a number. Okay, so anything that we can do to educate our parents about fevers, and that fevers are not necessarily a bad thing, that it's really our body's way of trying to help us fight off an infection, is important. Next slide, please. Now, Dr. Howard mentioned a lot of this already. I think if we are creating care protocols within our pharmacies about education and helping our parents understand what to do, we have to have a clear indication of when a child might need more treatment just than self-care. So all of these conditions here are something to think about. In addition to things like trouble swallowing, trouble breathing, most of these I think are very self-explanatory to us. If a parent calls and says, my child isn't able to walk, that's clearly more severe than just a minor illness causing a fever, right? So it's almost like you could have a checklist in your mind of these different conditions to think about when you are talking to parents about, these are kids that are going to maybe need some more treatment, right? Not that I would necessarily give this checklist to parents, but keeping in mind that these are things that you would worry about and when you would send off a child for more care. Next slide, please. So a little bit more about developing a care protocol for your pharmacy. If you're thinking about having a protocol, and I think that this would be a good thing, I was trying to find out what already exists out there, and I was surprised that it's very difficult to find this information, which then very clearly speaks to the need for us all to maybe develop something for ourselves to use. I want to stress the importance that within your care protocol, you need to calculate a patient-specific dose based on weight, okay? Now, there's a couple of reasons about this. Dr. Jack already mentioned some of them, that parents often don't know the doses. I think that it was demonstrated that more than half of parents and caregivers will give an incorrect dose of an antipyretic medication, with 15% of those parents giving a supratherapeutic dose. And so often I will talk to parents about how much does your child weigh, and then do the math for them and give them the dose in mLs, because we need to make sure that they're not using a dose that somebody had given them, 2 or 3 years ago. They have to recognize that their children are growing. I did see a question in the Q&A about, what if you have a child that is underweight, older, but a lower weight? If you calculate the dose based on their specific weight, this solves that problem. So not using an age-based dose, but definitely using their weight, then that would be good. The other thing about doses on products, many products have fixed label doses there. And they might be good at the lower end of a weight range, but as a child gets up to the higher level of that dosage range, we find that it's often underdosing the kids. So using the doses that Dr. Howard presented and calculating a specific dose and getting a specific mLs for patients is going to be more effective, okay? And then talking to parents to make sure that they understand how to measure the dose. Making sure that they have an oral syringe or they have an oral dosing cup and that it's marked correctly. I have had parents come in and they have a syringe, they bring out their oral syringe and they show me, and all the markings have been rubbed off because they've been using the same one over time. If that's the case, if you're able to, it'd be fabulous to give them a new one. And then when thinking about education, we want to, any kind of information that we can have ready to go in the pharmacy would be fabulous. Infographics that talk about what is a fever, when does a fever need to be treated, when should they use the medication, those kinds of things. And some information about educating parents in general, some tips for talking to children, include things like getting down at the child's level. So making sure that you're not towering over a child, this big scary pharmacist, get down on their level so that you're looking at them. I have also found that when talking to children, somewhere between age 3 to 4, you want to make sure that you direct your education to the child, because if the child is following along with you, then for sure the parent is going to be following along as well. You want to talk to a child maybe about something that they're interested in. So look at a toy that they have or a book that they have in order to start the conversation and try to make the child feel a little bit more comfortable. You want to be careful that you don't say things to the child that could make them feel self-conscious. So saying something like, oh, you're so tall, or oh, you seem very shy. Make sure you use your normal voice and use patient-friendly language so that we're not talking down to the child or talking above their level of understanding. Make sure that you use a calm and gentle voice as you talk to them. And then when you're making recommendations about how often to give doses if they're needed, linking it to activities of daily living. So instead of saying, you're going to take this medicine every 4 hours, maybe talking to them about their schedule and then helping them to plan out when they would give those doses. Now, when you're finished with your education session, it's important to ask the parent to talk to you about what it is that you just said. So often in clinic, I will say to a family, okay, now we just shared a lot of information with you. Can you tell me if you go home and mom or dad or grandma who's at home asks you a question, okay, let's assume that I'm talking to mom. So dad's at home and asks you, what did the pharmacist say? What are you going to explain to them? This helps you to understand what information did they understand from your conversation and maybe what was misunderstood so that it can be corrected. Also, at the end of an education session, it's very important to ask, what questions do you have? Instead of asking, do you have questions? Because if you ask, do you have questions, it's too easy for somebody to say no. But if you ask, what questions do you have, then you are assuming that we missed something and we maybe need to clarify something. Next slide, please. So this is an example of a patient education infographic that I was able to find that was actually pretty good. I think the one thing that is missing on here is the notion that not all fevers have to be treated, right? That we should only treat them if a patient is uncomfortable, as mentioned earlier. But otherwise, this is pretty simple. The language is pretty clear. There are pictures that go along with the messages, even though there are still a lot of messages included in here. Next slide, please. This is another part of a graphic that talks about fever don'ts. I think it is important that people do understand about not doing some of the older treatments that maybe grandparents or social media or somebody else might promote. So the idea of starving a fever or, making sure that somebody's bundled up very tightly. Actually, for very young children, if you bundle them up very tightly, that can actually raise their temperature. So some fever don'ts information is also important to include in our care protocols or our standard education that we're sharing with patients. Next slide. Now, when trying to think about how to develop an education program overall, I was lucky enough to see that a scoping review had been conducted looking at different educational interventions on fever management in children. And this review included 37 different studies, and out of the 37 different studies, 19 of them were directed to parents, and then 16 of them were directed to some healthcare professional. Some were a combination of nurses, doctors, pharmacists, some were only nurses, some were only doctors, but very interesting overall, I think. In the 37 studies, there were 9 randomized controlled trials and 21 trials that were pre and post studies. The rest of them were descriptive or cross-sectional or cohort studies. And the target or where the education took place was mostly in a hospital. So about 12 of the studies took place inside of a hospital and 8 took place inside of an emergency room. 13 of the studies took place in a clinic. Now, the authors noted that there was such a wide variety on what was taught and how it was taught and how it was assessed that the outcomes were not the same across the board. But all of the studies showed positive results with the exception of just 2 of them, which were aimed at healthcare professionals and looked at healthcare utilization. So I think that that's some good information for us to have. At the end, some of the recommendations that came out were that parents definitely prefer video training. And this could be very useful. I have not yet found an excellent video, but maybe this is something that we can look forward to working on, creating a video that would be a great educational tool for our parents about fever management. It's also recommended that as education is created, that we remember to keep it at a health literacy level that will target even our patients with a low health literacy, that we make sure the material is culturally sensitive, and that we have a way that there can be reinforcement, right? In a moment of high stress, when a child is sick, it might be hard for a parent to remember everything. So if we can take opportunities to educate parents when their kids are healthy, maybe it will help them to remember. Or if we keep these educational resources in an area that our parents can easily access, then that could also be helpful for the reinforcement. Now, educational experts will often suggest that a blended approach to learning, so some kind of mixture of video and online and face-to-face, is more effective than anything alone. And at the end of the day, the biggest takeaway, I think, was that there's just no wide-scale intervention that exists out there to combat fever phobia. So clearly something that is needed and maybe a call to action for all of us. Next slide, please. So at the end, I think it's important that we remember that fever phobia is real and it continues to exist. And anything that we can do to educate our parents about fevers and the role of fever is important. Making sure parents have an understanding of when it's okay to treat at home if needed, and when they should call the doctor or nurse practitioner for more care. When you do weight-based dosing, that is going to be the best option for treating a fever if a medication is needed. And when we educate our parents, using a teach back to assess their understanding, and maybe even all of us banding together to look at what we can do to better educate our parents about fever treatment. Thank you.
Thank you, Jill, for this presentation. Wonderful. We've been seeing like a lot of interaction from the audience, be it on the chat box and the Q&A or using the emojis. So thank you everyone for being there. What we'll be doing now is that we're opening the panel discussion in order to answer some of the questions that we have. So I would invite Jack and Jill to open. Yeah, perfect. We're all on screen right now. So we have a few questions that came to the Q&A. I do know that you've answered, for example, the one about the age or the weight of the kid in order to give them the right dose for fever. And definitely after listening to your presentation, we will go by the weight. And the most important thing, as you said, Jill, is that weight varies. So we have to keep on like telling the parents that when your child will have more weight, so you have to increase the dose. Thank you for this. This is like already answered. We have another question coming, and it is directed to both of you, Jill and Jack, which is about cold and cough and the fever that can come with cold and cough. So how shall we like tackle this subject, and how we can give a counseling to the parents about this? Jill, we start with you and then we go to Jack.
Wonderful. I think that's a great question about effective cough and cold medicine for children. I personally am not a fan of suppressing a cough in a child when they're sick. I think it's important that they need to cough out whatever is inside of their lungs, especially if they have asthma. So for patients that are over 1 year of age, you can use honey to help with cough, especially if there's like an irritating kind of dry cough as children go to sleep. There has been some literature to support the use of honey, but using a cough suppressant like dextromethorphan is generally not recommended. I think also other symptomatic care like using a cool mist humidifier or using any kind of saline spray to help clean out the nose can also be very helpful.
Thank you, Jill. Jack?
Yeah, I think it's effective cough and cold medicines in children might be almost an oxymoron. The evidence is not very strong for most of them, and the harms generally outweigh any minimal benefits that we might get from a lot of those proprietary products. So in terms of fever management, there's no evidence to say that either paracetamol or ibuprofen is one's better than the other. So that might be primarily dictated, to be honest, by parent familiarity and the flavors that comes in. That can be really important, something that perhaps we didn't discuss in a great deal today, is that the palatability of medicines can be quite important when it comes to children. Paracetamol itself is incredibly bitter, so that's why we often see quite strongly flavored medicines. The other products in cough cold for children that we typically see have a combination of multiple ingredients, which can include sedating antihistamines, cough suppressants, depends on what country you're in, what formulations they are, but there's combination medicines are actually not very safe to use in children, and there's no evidence that they work. So generally speaking, I'd be following the kind of less medicated options that Jill ran through, and then using either paracetamol or ibuprofen if fever is present.
Thank you. So because you mentioned the idea of palatability, and then during your presentation also you mentioned the idea of the packaging. So these two will affect also the choice, especially if we have the child coming with the parent. So what would you comment about that? So we do know that it is important, but how do we give more information about this to the parents?
I think it's unfortunately a little bit of a trial and error process between my interactions with caregivers. Generally speaking, it'll be like, no, I can't have that brand in that flavor. So one kid might like strawberry flavor, one child might like the orange flavor. I'm happy to have this brand of paracetamol, but not the other one because of taste. So I can't really guarantee that there's an easy way. A lot of them are color-free now, at least here in Australia. So in some ways that's quite useful too, because children may be attracted to or discouraged by particular colors. But I can't say there's an easy fix, because a child might like one medicine in orange flavor, another medicine that's orange flavor, the flavor is different and it's not going to be palatable. So it may be more about, is that formulation able to be mixed in with food or drink, depending on what we're giving. They may be other strategies, but unfortunately, sometimes we don't know until we try to give it how it's going to be received. It's like us trying foods for a first time, right? Sometimes we think it tastes fine, other times we go, yuck, I don't want that again. So similar kind of thing here.
Mm-hmm. Thank you. Jill?
Sure. I think taste is a very important question when it comes to children, and it definitely is a trial and error. Something that you can do if you have a product at home, acetaminophen tends to be very bitter, although the syrup tries to cover up that bitterness. So chocolate has been shown to mask bitter. So actually following up a dose of medicine with a little bit of chocolate sauce or chocolate syrup or something could help a little bit in a child, although depending on how they're feeling, they might not want that. Another tip that does not have any evidence to support it, but I use in practice, is the idea of trying to numb the taste buds beforehand. So a cold drink or a popsicle or an ice cube can sometimes numb the taste buds and then make it a little bit easier for the child to tolerate the taste of a medicine.
Perfect, thank you. We have another question coming about the different types of parents. So we have a question coming that's saying that some parents may have the phobia going up to anxiety, and we have the hysteria word going there, to other parents that seem like less caring about their child having a fever. So the question is, how can we explain to the parents that this is like something in between? We shouldn't have the phobia that you have talked about. At the same time, it's not something to neglect.
I think that recognizing that the parents are nervous that their child is sick is important, and listening to what the parent is saying, right? So that we can maybe respond to their thoughts. It's important to understand where the parent is coming from, what they know, before we can actually educate them then on the other side, right? So if a parent comes in and talks to you about, my child is sick and I'm very worried that my child is sick, then getting more information about what's going on with the illness and maybe doing some reassuring that this is common, children get sick commonly, and then seeing why is the parent so afraid? Is there anything else that we can do to reassure them, and talking to them about a fever is our body's natural way of helping us fight off an infection, and it's not necessarily a bad thing. And most childhood illnesses are limited to a couple of days. So a child should be feeling better within a few days. And if not, that's when we maybe need to think about getting some more care.
Thank you. Jack, anything to add to this?
Not particularly. I suppose on the other end, if you have parents that perhaps seems a little bit too nonchalant that their child's unwell, reminding them when it's appropriate that they seek further help. And that applies to the parents that are a little bit stressed about it as well. Look, this is what we would expect to be within the normal remit of a self-limiting illness like a common cold. But these are the times when I think you should seek further advice. So we're covering both ends of the spectrum by stressing what can be safely managed at home and when we should be concerned.
Perfect. Thank you. So we have a question that if fever is a fight of an infection, so it's a response. So when should we take paracetamol? When should we take the medication? So do we keep it natural or we have to interfere? Jill?
Sure. I think that talking to parents about only dosing medicine when a child feels uncomfortable. So they're laying on their couch or the bed and they're not interested in eating or drinking or something like that. Not to the point that a parent is worried that they need additional care, but that the child is just kind of not looking right to the parent. That is a reasonable time to give a dose of a medicine and see how the child responds to that. Normally the medicine will act very quickly within 15 to 20 minutes, and then they might start to see the fever come down and see their child acting back to their normal selves until their fever spikes again later in the day.
Thank you. Thank you. We'll go to another question, which is about fever post-vaccination and the use of antipyretic post-vaccination. Jack?
So in Australia, this might vary around the world. It's commonly actually recommended to give your child just prior to routine vaccinations. Antipyretics just prior to routine vaccinations, because we know that that's a pretty likely outcome of having a vaccine, that you may develop a fever. So there's no reason that kind of inactivates your body's response to the fever or anything like that. We're ensuring the child's going to be comfortable. For some vaccines in Australia, the recommendation is that you actually repeat the doses afterwards, regardless of how the child is doing. So it's quite challenging when we're looking at a global context. Of course, defer to whatever appropriate care protocols are in your practice setting. But on the whole, there's certainly no reason we should be telling parents not to use antipyretics around the time of vaccination.
Jill? Recommendations in the US, for example, or other, yeah.
Sure. We actually are a little bit different. In the last couple of years, there's been a little bit of evidence looking at a different response to vaccinations after giving antipyretics. So now we recommend not to give antipyretics before the vaccinations, but to wait until after, and if a child is uncomfortable, using them at that point in time. I'm always curious to see, if recommendations will change as more evidence comes out, because we definitely used to take the same idea that everybody should have some medicine before getting their vaccines.
Thank you. We've got a question coming from the idea of honey for the cough, and people are asking, is honey suitable for all ages as cough preparation? Because we have like some recommendations not to give honey before the 1 year, but we're talking about the natural one. So the answer would be?
So since I brought that up, I will talk about that. Definitely, we don't want to use honey in any patient under 1 year of age. We are concerned that there's a risk for botulism in kids less than 1. But over 1 year of age, it is reasonable to use honey for any kind of more dry cough that kids are experiencing. It seems to provide some soothing of the throat area and then maybe helping the cough that way.
Perfect, thank you. A question is coming about diclofenac. We've talked about the ibuprofen, we've talked about paracetamol, but we didn't talk about diclofenac. So is diclofenac recommended for children having fever? Jack?
We certainly don't use diclofenac in a community setting. I can't comment on it in a specialized hospital setting. but we wouldn't use it, at least here, so I can't necessarily provide comments. I'm curious as to whether there's really an instance where we would need to use diclofenac instead of ibuprofen or paracetamol, given those are usually readily available in most areas.
I think that that's an interesting question. In the United States, we do have naproxen over the counter, and so that is something that could be used in older children, although I agree with Jack that mostly acetaminophen and ibuprofen should be enough to treat the fever. And the idea of using a non-steroidal for a high fever, I've seen that before. Sometimes people think, oh, we're going to go to that because it's more effective. But as Jack already mentioned, there is not a difference in the efficacy for treating a fever between Tylenol and ibuprofen. It's really just a matter that ibuprofen will last a little bit longer than a Tylenol, but that's not a reason to use it for a number related to a fever.
Thank you. What about, we're talking about both of them, children who are like vomiting, having this like GI implication with the fever. So what would you recommend? So knowing the side effects of the ibuprofen. Yeah. Jack?
So we have suppository formulations available. If they're experiencing gastrointestinal symptoms, as in if they have diarrhea and vomiting with the fever, is that correct?
Exactly.
Yep. Yeah. So a suppository may be an appropriate alternative given that it avoids the oral route. That will depend on the formulations you have available locally, but they're not ideal because in a liquid measurement, you can get quite a specific dose. A suppository is obviously a fixed dose, so you can only get as close to the dose, give or take a little bit, versus if you were using a different formulation. Certainly that may be your only option if there is vomiting and diarrhea occurring. But I would probably also be checking to see if that child actually needs referral for medical assessment based on what they're presenting with.
Thank you. We had a question about persistent fever. So here, what shall we do? And when we say persistent, it means how long the child is having fever and how to continue the process. Jill?
Sure. I think that if I heard that a fever is persistent, my question is going to be for how long has the fever been there? Again, most of the time, childhood illnesses are going to be self-resolving within about 2 to 3 days. If a fever is present for more than 5 days, and there's no other, especially if there's no other symptoms other than fever, it is important that that child be seen by a medical provider. So often we tell parents to start with one medication, right? So using acetaminophen first and then dosing throughout that. If they need a longer, like they say, my child is not able to sleep overnight because the fever isn't lasting. If they're able to tolerate it, a dose of ibuprofen before bedtime might be helpful because it would last a little bit longer and maybe help the child to sleep overnight. I'm not sure that I'm completely answering this question. Maybe I'll see if Jack has anything to add there.
I think persistent, it's quite interesting. If we look at the way it's labelled in Australia is more than 48 to 72 hours of use, depending on the product, requires medical assessment. I think it's probably more of this fever without an obvious cause. So if someone has what you're pretty convinced is a common cold, for example, that can last for a few days, as Jill said, and we would expect fever to be there. Anything else, if there are coming back to gastrointestinal symptoms, if they were present for that long, that would be concerning because there's a risk of dehydration. So it's, I suppose, not necessarily a clear-cut answer. It really depends on what else is going on at the time along with the fever, not just looking at the fever in isolation of the child as a whole.
We have 2 questions coming about antibiotics and like parents like insisting on having an antibiotic, for example, while visiting the doctor's clinic when we have fever. So what is the link between this thinking about fever and antibiotic, and when should antibiotic be prescribed?
That's a great.
Both of your opinions. So we start by Jill.
Thank you. That's a great question. I think it's important to talk to our parents about so many illnesses are caused by viruses, right? Even if a child has an ear infection, very often it's going to be a virus, and we're going to try and hold off on giving antibiotics even for an ear infection. As Jack just mentioned, looking at the child as a whole is important. If a child has signs of a urinary infection, that is something that would clearly need antibiotics. But if it's a cold, a cough, a runny nose, something like that, even an acute GI illness, we're not going to use antibiotics to treat any of those things. So talking to parents about self-care and trying to manage the child at home for the first day or two and seeing how the child does in order to see if antibiotics are indicated. Because if it is a virus, the antibiotics are not going to have any effect. And I think this is where some reassurance is very helpful for parents.
Thank you. Jack?
Yeah, absolutely. I think this is a challenge in jurisdictions where we have some people on this call joining us from where you can give antibiotics without a prescription directly in the pharmacy. I think microbial resistance is a massive problem that we're facing on a global scale that shouldn't be news to anyone. So I think really educating about the role of antibiotics is challenging. I know it's hard when people are in front of you insisting, but in Australia, we removed children's cough cold medicines from the market about 10 or so years ago, and parents will still insist for those. So it's always like a product that we have which we ideally shouldn't give or can't give due to regulatory requirements. It's just educating, explaining the role. I see there's a question about sore throat and what appropriate antibiotic is and what the dose would be. Again, that's all based on local protocols. So is that throat infection likely to be bacterial? That's quite challenging to tell realistically without doing a swab. There's no real way we can necessarily tell that is strep throat versus a viral throat infection. So ultimately, we don't really have enough tools in the pharmacy to be able to make those diagnostic decisions. And more often than not, the antibiotics won't be appropriate. And if you think an antibiotic is needed, then the person probably also needs further assessment outside of our scope.
We'll be taking two more fast questions. One is, are suppositories safe for children less than 1 year?
Safe?
Safe. So this route is safe for children less than 1 year?
It will depend on what formulations are available and what doses they come in. So it's not necessarily, yes, you can, but it will depend on more what's available in terms of being able to administer. So long story short, yes, you can give suppositories to children under 1.
Jill, my last question for you is about, even though we have it's not 100% sure that sponging with water was important, and what we've seen during the presentation, it may cool the surface, but not exactly as a solution for fever. If we want to use water sponging, what would be the temperature of the water? Should it be very cold or regular water?
So if a parent is going to give a sponging bath to a child, I would recommend that the water be warm, not hot, but warm. Definitely something very cold could cause the child to shiver as it changes their outside temperature while their core is trying to catch up a little bit.
Perfect, thank you. We've had also one question about different availability of paracetamol in different countries. Unfortunately, we don't know what is there in different countries, and we apologize for this question. But the best is to go and ask the pharmacist or the health practitioners about this in the different markets. Thank you everyone, and thank you for the wonderful panel discussion. Jill and Jack, would you like to add anything before going to our final slides of this webinar?
No, thank you everyone.
That was a wonderful event and a lot of interaction from our audience. We really thank you. We know, Jill, it's early in the morning at your time. Jack, it's late in the day, so it's evening your time. This covered the whole timing, and we had also participants coming from different regions of the world. Thank you a lot. Noor, may you please reshare the screen in order to have the Final slides. We want to invite all of you to join us at the 81st FIP World Congress of Pharmacy and Pharmaceutical Scientists, which would be this year in Brisbane, Australia, from 24 to 28 September 2023, under the theme Pharmacy Building a Sustainable Future for Healthcare, Aligning Goals to 2023. Please note that those are important dates for you. May 1st, 2023 is the abstract submission deadline, and July 15, 2023 is the early bird registration deadline. For more information, please visit brisbane2023.fip.org. And for the next slide, we invite all of you to submit your papers, your manuscripts to the Pharmacy Education Journal, which is a fully open access peer-reviewed journal serving pharmacy education, workforce development, and we are as a journal here for over than 20 years. This journal is published by FIP, and we encourage all of you to submit your papers to the Pharmacy Education Journal. Thank you, everyone, and we will see you in our future events. Bye-bye.